Hello and welcome. My name is Pablo Castañeda. I will be your host tonight. I would like to thank everyone for joining us this evening for the NYU Langone Orthopedic webinar series. Today we have a great program. The title of the webinar today is "The Future is Here for Pediatric Orthopedic Surgery, Incorporating Orthobiologics, 3D Printing, and Advanced Imaging Modalities into Your Practice." Unfortunately, my co-host this evening, Dr. Karim Mazrouha, our partner, was unable to join us at the last minute, had an emergency and was unable to join. Fortunately, everything is good, but we're not going to be able to have his first talk. But despite that, we have a great lineup for you, and we hope to spend the next hour highlighting some of the cool technology and the things that we use on an everyday practice, which makes pediatric orthopedic surgery the most vibrant, innovative, and futuristic of the subspecialties within orthopedic surgery. So tonight's agenda is all of my partners here at NYU, and we're going to have a program which spans pretty much every anatomic region. And we're going to start with Dr. Mara Karamitopoulos, who is going to talk about gait analysis in your pocket. And I'm going to hand it right over to her to get started. So thanks again for joining us. Oh, and if you have any questions, there is a chat function. Please put your questions in the chat function. And from there, we will be able to take a look at these. And we're going to do 2 talks and then get to any questions. We'll also have some time, hopefully, to discuss these talks, but put your questions in there and then we'll try to get to those as much as we can. So with that, I will hand it over to Dr. Karamitopoulos.
Hello, everyone. Thanks for joining us this evening, and I'm happy to start us off. I will be talking about something that is advanced, but not advanced, and it should be a good palate wetter for all of you. We're going to talk about gait analysis in your pocket. So essentially, how to perform a gait analysis using some technology, but for those of us who don't have access to a full gait lab. So I have no disclosures. So in terms of a background, gait analysis, as all of us know who treat pediatric patients and also adult patients, is a critical component of preoperative planning for ambulatory patients with cerebral palsy. And gait analysis clearly has many applications throughout almost every aspect of orthopedics, but specifically we're going to be talking about patients with CP. Surgery is typically performed to enhance mechanics, enhance gait parameters, and having a really structured system to analyze gait is really paramount to maximizing patient function and also minimizing ineffective or unnecessary surgery. Gone are the days where kids used to have these birthday surgeries where they would come in for different lengthenings multiple times and have 17 and 18 surgeries. We really try to minimize that by effectively evaluating their gait and see how these different parameters interplay. So decision-making in gait surgery is actually quite complicated, as we all know. So you have to take a very good physical history and take into account what the patient goals are. Are the patient goals to walk better, or are the patient goals very specific to do certain sporting activities, to get into a stander, to walk for 2 blocks versus 1 block? What specifically do the family and the patient want to achieve? It's important to do a pre and intraoperative physical exam, to look at radiographs of the hip, the ankle, and the foot, depending on the areas of particular concern, and also to perform a gait analysis. Now, a formal gait analysis takes into account not only visual gait analysis, but kinematics, kinetics, EMG, dynamic PDO barograph, and all of these come together to really allow you to create an individualized surgical prescription to improve the gait. And a thank you to John Davids, from whom this slide is borrowed. So gait labs are awesome, right? Everyone would love to have a gait lab. They're super cool, but they're also incredibly expensive, have a lot of upkeep, and really require a full-time staff to be dedicated to doing this. Not just pediatric orthopedists to read the gait analysis, but having PhDs, having IT people, people who are constantly on board to keep this going. And that's something that, quite frankly, at most centers is just not achievable. But no gait lab does not mean no analysis. So you can be incredibly rigorous and incredibly standardized without having a lab. And that's what I'm going to hopefully convince you of today. So let's talk a bit about observational gait analysis. This is what all of us do all the time, right? You take a patient into the hallway, you watch them walk, you bring them back. If you're lucky enough to work at an academic institution, you discuss with your residents, what are you seeing? And these are really for centers, even with a 3D gait lab, but certainly without it, this is a critical component. And it's a frequent evaluation of gait pattern change. It's also helpful for children who are too young to cooperate with the formal gait analysis, or for kids with behavioral issues, so kids with severe autism or other diagnoses for which they are not able to comply with full gait analysis. So looking at your observational gait analysis, and we've all seen kind of schematics like this, it really presumes that the observer has a basic understanding of the phases of normal gait, a knowledge of what the common deviation patterns are. And this takes time in clinic. You have to look at the patient walk often multiple times, from the front, from the side, in the sagittal plane, in the frontal plane. Videos can be very helpful, and all of us with technology on our cell phones can do this effectively. And you have to have a standard way of looking at gait every single time. And really, that's how you don't miss things. So often when we talk to residents and fellows about this, we talk about looking at every segment separately. What is the hip doing? What is the knee doing? What is the ankle or foot doing? And the more you do this and the more experience you have with it, the more you can integrate it and do it quickly. But clearly in the beginning, it requires quite a lot of walking back and forth. You want to look at both the sagittal and the frontal plane, what's happening in stance and what's happening in swing. And that's going to really help you to identify where the abnormalities are. And a lot of this is making tech work for you, right? So even without a gait lab, we all have a cell phone. Many of us have iPads in clinic that our patients will do different things on, their paperwork before they come in. So these things are very available to us. All you really need is a camera. You can use your smartphone. You need appropriate lighting. And ideally, you need a hallway that's about 15 to 20 feet, which for most of us, if you have 2 or 3 rooms in a row, is that back hallway in your clinic with minimal decorations. You don't want to pick the one that's right near the poster board. And a very low-cost image stabilizer can be helpful, like a selfie stick or a gimbal. They're incredibly inexpensive, and they can really help so that you don't get that shake of someone holding their cell phone. So ideally, for an observational gait analysis video, provided you have a private area, you can do this. Again, most patients above the age of 3 or 4 are not going to want to walk in their underwear in the hallway, right? So you can draw out landmarks on the skin. If you were to do this in a formal gait lab, you would have stickies or electrodes that go on different areas, but you can draw them out with a magic marker. They must be in appropriate clothing, and that's really something to let the patients know about in advance. This is particularly important if you happen to have patients who religiously or culturally are not going to be walking around in bathing suits, even in a private area. So that's something to prep patients for and families for ahead of time. And this can very easily be done during a pre-op testing visit. So if you have the patients coming in for pre-op clearance, this can be a part of their pre-op visit. And this can be done either by an MD or, quite frankly, by a trusted PT. And all of us who work at big pediatric centers will have a really trusted PT colleague or two who's very familiar with how to take these measurements, and it can be really helpful. So there's a lot of apps, and the best thing to do is to really, draw from the sports performance world. There's a lot of apps that are commonly available, even more than this now, but these are ones that I've personally used that I like the best. I get no money from any of these companies. And when I did a search on Google yesterday, there are probably 20 or 30 of these apps that are out there. But these are the ones that tend to be the most common. Some of them are free. Some of them have free features. So you can start for free. And then if you want the more advanced features, you have to pay. And the pay ones range in cost from, Coach's Eye, which is $4.99. There are some that I found yesterday, obviously because of inflation, that are $12 or $13. But if you are comfortable, many of them you can do a free trial. And if you like it, I would proffer that $13 or even $20 is pretty low cost for something that you're going to use every day in your clinic. The advantage of these apps is that you can slow down the video. So many of these are some made for physicians, but many of them are either made for athletic trainers, for sports performance coaches, or for physical therapists. So you have the ability to slow down the video, even up to 1/8 of typical speed, which is really helpful. You cannot do that in your clinic. You can use a zoom function on most of them. It does allow you to measure certain angles, not everything you would get in a gait lab, but you can measure, peak knee flexion, peak knee extension, especially in the sagittal plane. There's a lot of things you can measure. So that's a helpful feature. And you don't need to take clinic time. I mean, really, you can video them at full speed, and then you can spend time afterwards slowing it down. And that's really helpful for pre-op planning, not just for the orthopedist, but if you have a trainee, a resident, or a fellow who's working with you, you can spend time with them and say, okay, let's slow it down. Let's look at the video. Let's measure the angles. What are you seeing? And it's really good as a teaching tool, even for your physical therapists who are going to care for the patient pre-op and afterwards, in terms of really helping them understand what we're looking at. So there's a ton of advantages. For those of you who want to be very rigorous, and I find this helpful, there's a bunch of gait scales that you can use. Probably the one that's the most in the literature that people are using, especially without a gait lab, because you can do it visually, is something called the EVGS, or the Edinburgh Visual Gait Scale. This is a 3-point scale for each area, looking at 6 different body areas in each phase of gait. And there's a composite score per side from 0 to 34. A low score is considered closer to normal. I actually hate the word normal. I prefer neurotypical, but we'll say normal because that's what they use in the papers. So this is an example of what that looks like. It is a bit fidgety. It's pretty easy to learn, but if you have a video, it takes a couple patients to sort of figure out how to do it quickly and effectively. But this is a very nice sort of objective way through your observational gait analysis to follow patients afterwards and to kind of, instead of saying, oh yeah, their gait looks better, to really try to get a sense more objectively through your observational gait analysis about what you're seeing. And you can actually get objective data. So you see here, this is comparing sort of the video with what the scoring sheet might look like. And there's excellent papers online about how to use this if you've never used it before. Again, it's a little finicky the first couple of times, but once you get used to it, it's actually quite quick. So with everything comes disadvantages, right? So we talked about why it's important using your technology. What are the disadvantages? Well, one of them is that observational gait analysis alone has in some studies a 60 to 70% agreement amongst very experienced clinicians, which means that 30 to 40% of the time, even people who do this a lot don't agree. Okay. There's no EMG analysis, obviously, and there's times when that can be very helpful for certain specific clinical situations, especially around the foot, where you want to answer very specific questions about what transfers might be more appropriate. You cannot obviously do that without a formal gait lab. And there's also no kinematics. So if you're looking for some things, for example, such as your rectus, whether your rectus is constantly turned on or out of phase, that's clearly going to be very difficult without kinematics, without a full gait analysis. You can see that they have a stiff knee gait and you can infer, but it's going to be a little bit challenging for that particular clinical question. There are some clinical questions that cannot be answered without this objective data. Most of them can be, but some of them can't. And you have to be willing, if you don't have a formal gait lab, to be wrong about 10% of the time, which is not 90%, but it's not zero. So it's important to know that. So this is the kind of data that one might get with a formal gait analysis. Clearly, your cell phone is not going to give you this information. So if you do have a patient that really needs rigorous data for a very specific clinical question, that would clearly be a case in which this would not be advantageous. So in conclusion, structured observational gait analysis can be a very good proxy for those without a gait lab. Technology can help us to further analyze gait for things we can't quite do just visually. And standard video and gait scales can help both with teaching and can save time in clinic. You say to the patient, we'll make a video, I'll look at it later. So it doesn't answer every question, but it does answer most questions to a high degree of clinical satisfaction. Thank you so much for your attention. please put questions in the chat. I will be happy to answer any and all of them. Thank you very much.
Excellent. Thank you, Dr. Karamitopoulos. I'm going to slide back in now, do like Chris Collinsworth, slide in. While we get the next slides up, I actually have a question for you. And since the time of COVID, we've switched to doing a fair amount of telemedicine. Mm-hmm. And I think there is many virtues to this, but I recognize there's limitations to it. But one of the things that I have found is useful is to have patients video themselves at home. So the gait that the child might have in the clinic might be different because they're doing a doctor walk for you. And it's always different, at least in my experience. So what I've done, and it's actually been pretty useful, although I don't do anything near as structured and elegant as you do, is have them walk at home. And I basically said the same thing, do it in a standardized space and try to look at this. Do you think there's value in doing home video before they come, or is it not really worth even spending the time? It's not really a scientific endeavor.
Yeah, so it's always helpful, even for either for kids with neuromuscular conditions or, quite frankly, neurotypical children, because they never do at home what they do in the office. And often the parents will tell you that. They'll say, this is awesome. It's not the way they walk. Right. I would never bring them in if they walked like this. So I think it can be very helpful. And I encourage parents to take videos, especially if there's a clinical concern. So if anything has worsened, if the gait is new, if there's new limping, it can be very, very helpful. There have been some studies, including one from here, looking at sending people home with activity trackers, for instance, Fitbits and different devices like that, to really measure things like step length, number of steps, and sort of some of those objective measures. No one's really looked at the correlation of, how accurate is it to have parents film their kids, but I think it gives good data. I don't know that it would be enough for me to make a surgical plan, but certainly if it's a patient I know, it's a patient I'm concerned about, those can only be helpful. But I don't think we're at the point yet, short of telling parents to download all these apps. I don't think we're at the point where the parent video is going to supplant any kind of, structured gait analysis. But it's an interesting idea.
Yeah, absolutely. And you've done a lot of work as well in the health disparities field, which, you and I have smartphones, but we know that the reality of many parents and families is they might not have the technology. So I think there's a lot to do with that. And I think that was a great sort of introduction to, how we're doing things and how we can take things to a slightly more advanced level. So great talk. And we're going to move on with my talk now. And again, thank you all for your attention and thank you for joining us. Dr. Karamitopoulos will be sticking around for some questions at the end of this talk, and then we'll move into the second block to move on to some other stuff that we're talking about. So what I figured we would talk about is some of the new imaging that we can use specifically in the field of hip preservation surgery. And the title is Incorporating Volumetric and Cinematic Imaging in the Way You Plan and Execute Hip Preservation Surgery. I have no disclosures that are relevant to this talk. So I like to start with a case, and this is a patient who has multiple hereditary exostoses, extensive involvement of both proximal femurs. And orthopedic surgery is really just anatomy and common sense. And if you look at this, you can see that the anatomy is not normal. And if you can figure out the way it should be, resolving how this should be treated should be relatively simple. It's got a big bone bump. We want to take that bone bump out. Specifically, when you talk about this orthopedic condition, which we see relatively frequently, MHE, multiple hereditary exostoses, we know that about half of patients who have this condition will have an osteochondroma about the hip. And impingement is not the same type of FAI that you can treat by an arthroscopic osteochondroplasty. Okay, this is not a typical sports case. And we know that these patients have trouble with their activities of daily living. So if you try to use these typical measures of morphology of the hip, center edge angle, acetabular index, Sharp's index, alpha angle. They don't really apply when you've got these weird pathologies. These are great for subtle abnormalities, but they don't really apply. So you have to begin to use some slightly more advanced imaging. And this is just a very simple way of using it, cross-sectional CT. And you can see ischiofemoral impingement from this large osteochondroma coming off the medial aspect of the neck. And at the bare minimum, advanced imaging for these hips should include CT. But with modern volumetric and cinematic rendering, I think this will help you understand how we can actually incorporate this, because not every case is quite as spectacular as that MHE case I showed. This is an interesting example of why we do think that these advanced imaging modalities can provide so much more value. Up on the upper left of the screen, you see an AP pelvis of a child who had cerebral palsy. And that right hip, the hip on the left, looks a little sublux, looks a little dysplastic. The neck shaft angle looks a little strange, but looks like the hip is in. If you look at Shenton's line, it actually looks pretty decent. And then when we got a CT and especially a 3D rendering, you can actually see this hip is actually dislocated. And the version on the femoral head has created this mismatch. And now there's a huge gap, and this hip is unstable and is in trouble. So at the bare minimum, you can see how advanced imaging has taken us to a much better understanding of this pathology. So just by doing simple cross-sectional CT, you already have an advancement in the way we can evaluate these cases. Here's another case I was able to treat who had a very large osteochondroma. But this one highlighted how even these 3D renders aren't enough. So on the left, you see an X-ray. Clearly, that's a very abnormal hip. You can't really make out any normal anatomy. And that huge osteochondroma, which had a larger cartilaginous part than the bony part, was actually pushing that hip out and creating the subluxation. But we couldn't really tell where the pathologic tissue ended and where the healthy tissue began. So you see this widening of the neck, the coxa valga, and you can see how big that mass was. But at the time of surgery and doing a surgical dislocation, you could actually see that the head was normal. It's like this island of hyaline cartilage floating in this sea of chondrodysplasia. So, this is a case where we would have liked to have understood exactly where that healthy tissue was, and it wasn't quite as clear as you would think. Despite having this 3D rendering, which is an impressive image, it didn't really show the pathology as well as we would like. And to take that a step further, when you begin to move into these slightly more subtle types of impingements, where it's not quite as obvious, then we need better ways of measuring and detecting this. I believe it was Peter Drucker from management who said, if you can't measure it, you can't improve it. So we need more objective ways of measuring what we do. And we can measure this in alpha angle, but this still remains a two-dimensional representation of a three-dimensional structure. So up on top, you see these CT renderings of a hip that had a moderately sized cam lesion at the osteochondral junction there in the head-neck junction. And when we did 3D reconstruction, we were able to do 3D rendering and volumetric rendering. By quantifying the amount of hyaline cartilage, you can actually calculate how big the head is, how much the healthy portion is, which is the blue part of this. And then the red is actually pathologic tissue, which wouldn't correspond to a typical hip and is obviously creating the abnormal anatomy in this hip. So we can go back to this case of a 10-year-old girl who has these large MHE lesions. And you can see how that neck shaft angle is increased. And I figured that because the neck shaft angle is increased, I'm an orthopedic surgeon. If the angle's too high, I'm going to make it too low. In reality, we ended up doing a varus osteotomy, and it may have been too much treatment. We did this through a surgical dislocation approach, which you see here. This is on the left of the screen, you see the gluteus medius at its insertion into the greater troch. On the right, you see the continuation of this in the vastus lateralis. So we did a trochanteric flip osteotomy and a surgical dislocation, and then did an osteochondroplasty, took down all that tissue. And because I thought the neck shaft angle was so high, I did add a varus-producing osteotomy. Now, if you look at the way we recontoured the neck, perhaps that varus-producing osteotomy wasn't even needed. Maybe all she needed was the osteochondroma resection. But when I'm measuring this with typical measures, it didn't give me the full picture of what this is. So I was aiming for a neck shaft angle of 130 degrees, but when you shave off the osteochondromas, maybe you don't need to do as much. And fortunately, the surgical dislocation approach allowed us to see and evaluate the hip in a global fashion and look at this in from every aspect. So patient was kept toe touch weight bearing for 6 weeks, returned with signs of initial healing. I do prefer to see this before I do the second hip. I think this is too much surgery to try to do simultaneously. During this time, she was working on some physical therapy and strengthening. And at 6 months, she comes back with a healed osteotomy on the right side, which you can see now has a improved neck shaft angle, and she's having symptoms on the other side. So she gets the exact same procedure. Here we're producing the trochanteric flip osteotomy to take that portion anteriorly, dislocate the hip, use a burr to shave down the osteochondroma, the osteochondroplasty, contouring of the neck. But it's tough to know how much you need to shave off. So this is an area of research for us, is using volumetric analysis. And the next step may be to actually bring in navigation, which we'll hear about more a little later on, how you can incorporate this to a different anatomic region. But perhaps that's a way of doing this so that you can limit the extent of your burr and not necessarily take away any healthy tissue. So I aimed for a similar neck shaft angle of 130 degrees. By doing this through a surgical dislocation, you can distalize the greater troch. It was distalized about 1.5 centimeters. You can see we used the same locking plate configuration for this. And 6 weeks out, she shows some healing. And you can see how the right hip now shows significantly increased range of motion. So she's healing on the left. We'll continue with some physical therapy. And this is the final x-ray, which I took after taking out the plates. The screws from the trochanteric osteotomy remain. But you can see an anatomy which is much improved. These hips, which were subluxing, now look pretty congruent and spherical and a very good result. But again, we would like to be able to quantify this. And not every case is quite as spectacular as seeing MHE. More often than not, you will see hip pain in an adolescent, and it might be a slightly more subtle type of cam deformity. So these are x-rays of a patient who had significant symptoms on the left hip and had a mild cam lesion, but it wasn't anywhere near what I would expected to have seen given his symptoms. And by doing a CT, we were able to get volumetric rendering of the femoral head, which demonstrates the amount of healthy tissue. And then you see this bump, this big cam lesion, which on the right is rendered in red. And that's the abnormal tissue. So we now know there is an anatomic deformity, and we can measure this and get volumetric measurements on how much pathologic bone there is. And the next stage to this is to do cinematic evaluation of impingement. So this is a really cool 3D reconstruction of an MRI of a hip, which didn't have terrible looking anatomy. And then what we've done is taken the other side, flipped that around to use that as a control, rendered that onto it using some very cool proprietary software. And then you can virtually take the hip through a virtual range of motion, which is what we're showing on this video, and compare the right to the left hips. And this gives you a very accurate measure of where that impingement occurs and where you could potentially have symptomatic impingement of the proximal femur and the acetabulum. So by drawing this, you can see just how limited that right hip was compared to the left hip. So all the images on the top side of that arc is the asymptomatic left hip, and everything on the bottom side of that arc is the symptomatic right hip. And you can see how this was pretty much global impingement going from the very back of the acetabulum all the way to the front. This is a classic sort of pincer type impingement. But again, this shows you exactly how much you can expect to have from this impingement and how much can actually be affecting the hip. With that, it allows our correction of this deformity to be much more accurate. We know exactly where we need to go, and we can take away as much bone as is predicted by this model to be causing this symptomatic impingement. So this is, again, the same case after doing a surgical dislocation and repairing that osteotomy. And now you can see that femoral head does have the recontouring on this, which now is avoiding this impingement. It's actually on both sides of the joint. You can see both the acetabulum and the proximal femur have now been recontoured to allow for slightly greater range of motion. So idiopathic FAI in adolescents is not uncommonly caused by conditions such as slip upper femoral epiphysis. And we've now done this for 16 hips, which is a relatively small series, but using this method, we can accurately measure how much resection is being taken. The mean age was 15 years, and most of these were male. And most had had symptoms for around a year, ranging from as little as 6 weeks to up to 10 years. Most of these were CAM-type impingements. One was pure pincer, and there was 3 mixed types of impingements. So how does the volumetric assessment actually help? This is what we do. We get the images of the hip on the left, the 3D reconstruction, and then recontouring of the femoral head in pink with a different color chosen for the abnormal tissue. And this can actually be quantified. So if the femoral head in its entirety measures 56.3 cubic centimeters, and we see that that bump is 3.29 centimeters, we know exactly how much bone needs to be taken off, taking out the guesswork, because you can use this, the burr with a suction tip and know exactly how much tissue has been resected. And the mean volume that we resected from the series was actually just under 3 cubic centimeters of bone. The results have been very good with this. This is pain on a visual analog scale, which preoperatively was at 6, and 2 years after the procedure is maintaining at less than 1. So basically the pain has gone away. Function, we measured using a modified Harris hip score, and the pain and the function improved from a pre-op of just under 80 to above 90 at 2 years and maintaining good function of the hip. Radiographically, another way of measuring this is just measuring the CAM type angle. One of the weaknesses of this is, of course, we're unable to get post-operative imaging because no insurance is willing to pay for it. So we're basing this on radiographic measurements. But if you look at the classic CAM type, the alpha angle has gone from a mean pre-op of 58 to a mean post-op at 2 years of 48.9. So I'll conclude on this case again. Here's back to that case, which has a very good result. But I think volumetric and cinematic imaging can actually improve the accuracy of correction of surgery. And if we improve the accuracy and improve our surgical technique, then it makes sense that the most people who stand to benefit the most from this are the patients, who ultimately will have better outcomes because we will be more precise and more accurate in measuring these types of resections. So I will end there. And again, thank everyone for their time and your attention. And we're now going to check to see if there's any questions. And yeah, there's a couple of questions that have come into the chat. Both of these are actually for Dr. Karamitopoulos. So,
oh, wow.
First question is,
lucky me.
And this is a great question. Is there any way to obtain ground reaction forces from these apps?
That's an awesome question. So thank you, Dr.
Michael Leibowitz.
Michael Leibowitz. No. So there are a couple of apps that I've seen where it incorporates a special force plate bought separately, like a little sensor that goes in your shoes. This particular app, and there's only one that I've seen that does this. And it's meant mostly for runners to do like a running gait analysis where they send you these sensors that you can buy that go in your shoes. You can get some of that data from that particular app. The accuracy of it, I have no idea. But a pedobarograph setup and to do basic ground reaction stuff, if you were to purchase that kind of gait plate, it's obviously much less expensive than like a full gait lab. So there are people who will use those both in concert. So probably more wearable technology that will come out. I just don't know very much about what the accuracy of that is. Great question.
Yeah, I mean, I think it's a great question. I think that's kind of taking it to the next level, right? Mm-hmm. Because you do need some more advanced technology. But I mean, I would be, it was interesting. I was talking to one of our ENT colleagues. Did you know that they're sending these home endoscope kits to people's houses? Mm-hmm. So we may be at the point where technology, you could probably have these ground reaction plates, not necessarily having the whole setup of having like a full gait lab.
Yeah. So, I mean, the holy grail, right, is to get something that's cheap enough and reliable enough that you can purchase them, send them home with people and put them in their shoes and then see how they walk when they're not with you, which is what you were talking about before, right? Yeah. And to be able to quantify that, I don't think we're quite there yet. There's some companies that I've heard about who are trying to do this in a way that's cheap. A lot of engineering schools and engineering students that I've heard about. There's a lab at Columbia and a couple of other labs that are looking at this to try to get a cheap, reliable way to have something you can put in people's shoes that gives you tons of data. And I think once we get to that point, we know that it's accurate and you'd have to test it obviously against rigorous gait lab data to be able to make clinical decisions. I mean, that's the holy grail, right? Is to be able to send someone home with something and make clinical decisions.
Put it in their shoe and then have it tell you.
Yeah, I mean, we're maybe 5 to 10 years away, I think, from that, but it'll get there.
And there's another question here is, do you have any gait analysis courses that you can recommend?
Yes, there's a lot of really good ones. And the great thing about pediatric orthopedists in general and people who do gait and CP specifically is that they're all amazing. So if you can't go to a formal course, but you have a gait lab nearby, people are really lovely and email people and they will let you spend some days with them. But there are really good courses. There's a great one that Gillette runs every year, and there's another great one at Connecticut Children's. There's also a great CP course that DuPont runs every year as well. But if you can't make it to one of those and you do have a local gait lab, just email someone and ask to spend time with them. And I found, from personal experience, people are really giving and quite lovely with their time. I also have, people that I've sent videos to and say, hey, what do you think? Do you think this person should do a gait analysis? And people are really helpful. So, don't be afraid to send an email because it leads to a lot of good clinical collaborations.
Great. Yeah, it's easier in the hip world. We just send pictures of the hips around.
Much easier.
Makes life easy.
Well, hips are easy. We all know that.
Of course they are. That's why I do them. Anyway, I think this has been a great beginning to the webinar, and we're going to go ahead and move on. There was no questions for the hip, which is, I guess, good. So if you do have any questions, again, feel free to put those in that chat function. But now I'm going to hand it over to another one of my partners, Dr. Andrew Price, who is going to talk to us about some really cool custom-made cutting jigs for improving the accuracy of correction of limb deformity. Andy, take it away.
All right, so I'm going to talk about custom-made cutting jigs for accurate correction of pretty much upper limb deformities. And I have unfortunately, no disclosures. Anyway, deformity correction is a very important part of pediatric orthopedics. And if you have a deformity in one plane, this is fairly simple to correct, not a problem. But oftentimes deformity, especially in the upper extremity, can involve more than one plane, often 3 planes. And surgical planning can be very difficult and often complicated. With the rise of 3D technology, this has spawned companies that can assist with the planning of very complex osteotomies. So, for example, forearm deformity is a very complex deformity that can affect not only cosmesis, but elbow flexion extension and forearm rotation. And there are a host of conditions that will lead to forearm deformity, primarily multiple hereditary exostosis that Dr. Castañeda talked about, Madelung's deformity. It can be longitudinal deficiencies. Arthrogryposis can cause deformity. Brachial plexus birth injuries also can have a deformity of their forearms, as well as any fracture malunion. And here is a case of Madelung's deformity. So the surgical planning for these things, if you just use a 2D X-ray, planning is less reliable than using a 3D plan, especially for any axial correction. There are studies that now show that using this 3D technology will give you a lower morbidity, as well as patient-specific surgical guides that make it easier to do. Studies have shown that the surgery time is shorter for both forearm and even elbow corrections using this 3D technology. Unfortunately, this requires the use of CT scans of both forearms, and hopefully the future will be able to use MRI scans to cut down on the radiation exposure. There are specific requirements for the radiologist to follow for these companies to make your surgical guides. These are some of the things: 5 by 12 by 5 by 12 pixels, 6.6 centimeters of slice thickness, and certain amount of dosing so that the kids don't get over-radiated. If it is a unilateral deformity, what they often use is the opposite arm. If there are bilateral deformities, they'll use a sort of a virtual healthy forearm. And what they'll do is, using 3D technology, they'll print out through a polyamide guide, cutting guide, and also make models of the bones and test them out. So here is a case of mine. We had multiple hereditary exostosis, where you can see on the left are the bones, the deformed bones that the company was able to isolate using their technology. And on the right is what their planned osteotomy was to correct the deformity. On the left, you'll see this is just the radius, but on the left, what they come up with is a surgical cutting guide, where you will take K-wires and pin it to the appropriate portion of the bone, and then there'll be sort of slots that will guide your cutting. They will also oftentimes have other jigs that will help you contour a plate for the fixation of your osteotomy. And on the right there, you can see the postoperative appearance after the cutting guides have been applied. Another deformity that is really nice to use this technology is cubitus varus. And this is one of the more common ones after a malunion of a supracondylar fracture. Not only is it a cosmetic deformity, but a recent article by Christine Ho shows that there are also late complications that we pediatric orthopedists don't always see, such as posterolateral elbow instability and tardiolnar palsy. So these deformities are often in 3 planes. They will not only have varus deformity, but they will also sometimes be malunited in extension and also internal rotation. So here, what they'll do is you'll take CT scans of both elbows, and they'll actually put these, put them right on top of each other to come up with an optimal osteotomy that would restore the normal anatomy of the elbow. This will guarantee the best elbow alignment and avoid any kind of shortening or prominence of your lateral condyle when you do these cubitus varus corrections. They basically, they will do a preoperative simulation in their lab to make sure that the cutting guides work and then send them to you. I would advise anybody who wants to use this technology to be very involved with the engineers there, because they are not orthopedic surgeons, and you have to be very specific and make sure that they know exactly what you need. This is a slide. On the upper left-hand corner is a picture of the cutting guide that they made in their model, their pre-made model. On the bottom left is the exposed bone with the cutting jig on this exposed bone, and you use K-wires to mount it before you do your osteotomy cut. On the upper right-hand corner, once you do your cut, you stabilize the fracture with K-wires, and then, in this case, double plating for a supracondylar humerus fracture. So, to my knowledge, there are basically 5 companies that I know of that deal with this. As I said before, I have nothing to disclose here. The Materialize is one of the older companies. Medix 3D is an Italian company, and Nuclip is a French company, but they all basically do the same. They utilize 3D technologies and provide cutting jigs to optimize your result and keep your surgery time down. So in conclusion, 3D simulation with cutting guides offers a more accurate correction of 3D dimensional deformities. This requires CT scans and consultation with engineers to fabricate the cutting guides and sometimes jigs to make your plating. There are studies that have shown that there is lower morbidity and shorter OR times when you can use this type of technology. It will optimize your cosmesis and function and leave a lot of the guesswork out. Thank you.
Thanks, Andy. That is really cool that we can take this to the next level. I think that, as I said, I think that anything which improves the accuracy with which you can provide these corrections ultimately should translate to better outcomes. So it's almost a similar concept to what I was showing. You're just taking this to the next level by actually having these custom-made cutting jigs. One question for you from a practical standpoint, Andy. So does insurance cover these?
Yes.
All the time? You've never had any issues with this?
I haven't. And what happens is a lot of these companies will have a division as part of their company that will help to obtain the insurance restoration. So to answer your question is that these companies help you getting authorizations for their cutting jigs.
Amazing. Well, okay. Again, reminder to everyone who is listening: put your questions in the chat function for us, and we will get to some questions at the end of the last talk. So years ago, I was asked to give a talk about the future of pediatric orthopedics. And all I did was stand up and say orthobiologics and navigation. And that's the future of pediatric orthopedics. So unfortunately, we didn't have the talk on orthobiologics, which is an entire webinar in and of itself. And maybe we can look out for that in the future. But we are going to have a great talk on how you incorporate navigation into scoliosis surgery by my other partner. And it's my pleasure to introduce Dr. Jody Litrenta. Jody, take it away with scoliosis.
All right. Well, thank you so much, everyone, for joining us for today's topics. And I've really learned a lot from the first 3 presentations. And I am here to add to the knowledge and talk about the present and the future for pediatric spine surgery and the role of navigation in scoliosis. So scoliosis really represents a wide spectrum of pathology from, the idiopathic etiologies to early onset, congenital, neuromuscular, and syndromic causes. And you can see you can really see and appreciate the differences here, looking at these 2 examples, an adolescent idiopathic spine and the syndromic Marfan patient with kyphoscoliosis. These are the pre and post-op x-rays of each one of these cases, and they will both have their own unique technical challenges for instrumenting the spine, and really is the reason for introducing today's topic about the role of navigation. Spinal instrumentation for scoliosis has really long been an area of interest in evolution, and this was starting with the Harrington rod, which you can see pictured here. Posterior fusion techniques have included advances from Cottrell, which took into account the three-dimensional aspect of the spine, techniques such as rod rotation, the Luque rods, which were initially very useful in neuromuscular scoliosis, progressing to hooks and screws, hybrid techniques, and all pedicle screw constructs. Pedicle screws were first actually introduced around the 1970s by a French surgeon, and over time, as surgeons have become more comfortable with safe placement, we're continuing to refine that technique. There are many methods by which the pedicle screw can be placed, starting with the freehand technique, which is done by just knowledge and identifying anatomic landmarks. And of course, these are going to vary in location and where you are in the spine. And you can even see varieties, for example, within the thoracic spine as pictured here on the right side of the screen. Fluoroscopy can be a really nice adjunct to really help you identify the pedicle, and you can have varying levels of reliance on how many images you're going to take based on each individual surgeon's preference. And in this image, you can see here that I have some wires in the more proximal vertebral levels to find the pedicles, which are then verified with fluoro. But the fluoro can also be used to find the starting point of the pedicle by angling the machine in line with the pedicle at that given level. And that can really facilitate that placement. So finally, navigation. This is an exciting introduction we have that allows 3D visualization of each pedicle at each of the levels that are going to be instrumented. And you can see why this especially is exciting in more complex cases with varying morphology. So the real rationale for navigation is just to improve our accuracy, whether it's a complex case or not. While the placement of pedicle screws is largely considered a safe technique, it's not entirely without risk. And there's a narrow margin of error. You can see here that you don't want to wind up with screws in the canal, and you also don't want any other structures that are violated, such as the aorta, which you can see clearly marked here. Okay, so how does navigation work? How does it make scoliosis surgery safer? The first step is you take a scan of the patient that represents their individual anatomy. Then the navigation system is registered and the instrumentation can be tracked over the landscape of that surgical field that was initially scanned. And finally, it will project the trajectory in a realistic three-dimensional model for you that you can use while you're instrumenting the spine. So in our current workflow, the scan is most commonly done after exposure of the spine. This example here is showing an O-arm, which really can capture the largest field of view quickly. Some of the other ways you could scan the patient would be three-dimensional fluoroscopic units, CO-SEAM. These can be used to acquire the image. You can capture about probably 4 to 6 levels at a time. And that's going to depend on the size of the patient and obviously the location of in the spine, right? The lumbar vertebrae are going to be bigger than the thoracic. So this may mean that in some cases you have to take multiple scans to cover the entire scoliosis surgical field. While the scan is taking place, you have a tracker that's somewhere on the field, and you can see in the image, it's this tracker that has the silver balls on it that's then recognized by the navigation system. We very commonly will take that tracker and place it at the most distal aspect of the surgical field, or you could put it in the center, and there's advantages to both. You don't ever want to disturb that tracker or it's going to throw off the accuracy of the navigation system. So if you put it in a distal aspect of the field, it's much less likely that you are going to bump it and then introduce error into the system. But it's also true that the system is going to be a little bit more accurate if that tracker is placed in the center of the field. So you're never working that far away from it. And that also improves the accuracy of the system as well. So you can see there might be reasons for using each one. Looking at this X-ray, that fluoroscopic image on the left is showing that the tracker was placed, or replaced, I should say, after instrumenting those distal 5 levels. It's attached to the spinous process. And then what happens next is you then do another scan moving proximally in the spine, and that tracker stays in place to help you as the screws are placed. And the way that navigation is really helpful in placing these screws is it shows you in real time the trajectory. So this can be using a simple pointer, or the technology can be incorporated into whatever instrumentation you typically use to instrument the pedicles. So it can be incorporated into a drill, the awl, or the screwdriver, and really helps with the perfect placement of each screw. And what you see when you're using the navigated instrumentation is that it will show you in real time the trajectory. So you can see I've kind of drawn it in here, but it will show you exactly, am I pointing directly down the pedicle or not? And it can also be shown in multiple planes, and you can manipulate the orientation of those 3 planes to really get the view that you want, the view that matches the morphology of the vertebral level that you're working on. Finally, it's not just placing the screws. It is, I don't know that I can, can I play this video? Yes. Okay. It's not just placing the screws, but it's being able to check your accuracy after they are placed. So this was a short video just showing a scan that was done after the screws were placed via navigation, so that they can furthermore be checked in a 3-dimensional way while the patient's still asleep in the OR. A common criteria that we use for the good placement of pedicle screws is to either say there's no cortical perforation, or there's a perforation within 2 millimeters, whether that be medial or lateral. And when we compare navigated to non-navigated techniques, this study is looking at fluoro assisted freehand technique versus using a O-arm or 3D C-arm. And importantly, they looked at a wide range of scoliosis patients from different etiologies. And they found that in general, there's really no difference in terms of the blood loss or the length of stay of these patients, but they did see better accuracy in the navigated screws. So that you had grade 2 to 3 screws, which are those screws that have more than 2 millimeters of perforation happening in 11% of the non-navigated and 4% of the navigated screws. And then also importantly, the study had 1 return to the OR for screw position, and that was in the non-navigated group. Here's a systematic review that also, again, also demonstrated improved accuracy and placement using navigation, also fewer returns to the OR, blood loss generally equal in both groups, with slightly longer times happening in the navigated group of 30 minutes, and a trend toward higher radiation. They also did have some returns to the OR for screw placement, and this didn't happen in the navigated groups. Finally, I thought it would be great to kind of highlight this study because they talked both about the benefits of using navigation, but also highlight some of the challenges and give some additional insight. They mention, of course, that navigation did improve accuracy, but they caution surgeons to be aware of instrumenting more than 6 levels away from the probe or the tracker. That's what I mentioned earlier. The farther you get away, the more error you can introduce into the system, and your trajectory may not be perfect. So to be aware of that. They also kind of made some interesting comparisons about the amount of radiation that's used. For example, in 1 scan of OR equaling about 8 85 seconds of fluoro, and noting that in general, you can actually decrease radiation even in these navigation protocols by simply using a lower dose. That's generally very safe in pediatric patients. It could be an issue in heavier patients. So something to consider there. So in summary, I think the future is also here for scoliosis surgery. It's a really rapidly evolving technique. It has the potential for improving our accuracy, managing complex scoliosis deformity, but also it still has especially important indications for helping with efficiency in safety in any of our scoliosis patients.
Excellent. Thank you, Jody. That was a very nice talk, which is typical of your talks, very well organized, and we appreciate you putting that into it. There is actually a question kind of for both of you, which is, are there similar 3D printed guides for pedicle screw fixation, similar to the 3D printed model cutting jigs used for extremities? So it's kind of combining the two. Jody, I'll let you tackle that.
Yeah, you can print 3D models of the spine. And I think that particularly in a very complex case, it is maybe nice to do that and actually, handle the deformity that you're going to be working with. I also just think, the information that you get real time in the OR when you're there is really valuable and really helpful. So that is almost even more advantageous than I think in most cases printing out a guide.
Pablo Litrenta, I have a question for you. I'm wondering if you could speak a little bit about the use of this technology in terms of graduate medical education. So in terms of educating our residents and our fellows, what have you seen in terms of the role of that and how that can be used effectively for training programs?
Yeah, I love that question. So I think one of the things that's really nice about it is that when you're using navigation, the people that are in the room with you can really sort of follow along, right? So, you put the probe up to the pedicle, you show your angle, everyone can look at the screen and really kind of, understand what's happening. So I think it's really nice for a training tool, but I do think the downside is that you have to be careful to not completely abandon learning anatomic landmarks. And it's very easy when you have the screen there to just turn and look at the screen and not be looking at the spine. So I think you have to be a little bit careful of when you're teaching someone how to place the screws, striking that balance.
Thank you.
Yeah, I think that's, a follow-up to that question, which is great. I agree. I think this is a topic sort of in training. I think residents today rarely will see a pedicle screw insertion freehand in most instances. So, right. Do we need to train them for that, or do we need to make them more proficient with this sort of upcoming technology, which if they don't understand that, then they're also going to have issues with? What do you think, what's the balance between those two?
One thing I didn't mention is that the navigation is excellent, but if you are way off, it won't save you. So if you're not, the closer you are to putting the probe, the screwdriver, getting to the pedicle, if you put it on the spine and you're close, it really helps you. You can manipulate it a little bit to make it perfect. But if you are struggling a little bit and you're a little bit too far away, sometimes that can be difficult. So I think it's going to work the best in the hands of someone that has some comfort putting pedicle screws in, and it's going to just make you better. But it's not going to. It's going to improve your accuracy, but it's not going to replicate. It's not going to take the place of experience.
Love that answer. There's a question, which if I'm understanding it is there an age limit for this? Do you So you mentioned CT. I guess, is there an age limit for doing this? Do you have to get a CT, or is there any other way of getting around this and then maybe using optics in the OR?
I mean, well, you have to scan them somehow in the OR with the tracker on them so that the navigation system, recognizes it. And again, you can use a low dose protocol. I'm not sure what else you could do to acquire, a 3D image. I mean, there's obviously the 3D fluoroscopic images, which is essentially the same.
Yeah, I've seen it can be done with MRI. And again, there is some systems that are now using visual landmarks instead of using an intraoperative CT. So it actually,
like on the skin and things, sure.
Right. Which maybe would allow that, but sort of fun stuff to come in the future.
Right.
Okay, well, if we don't have any other questions, and I don't see any more in the chat box, what I am going to do is actually give everyone back 20 minutes of their lives, because we still have 20 minutes to go, but I think that no one will complain if we end a little earlier. So with that, I will once again thank you. Thank you to our amazing support team here from the CME office, Kat, Friedman, amazing. And all of the tech support team. It was seamless, and you guys did a great job speaking, which made it even better. So thank you to everyone, and good evening.